in Nairobi, we are having an interesting observation. At KNH, we've generally had very few cases. I think over the last week or so, we probably had just about 10 to 11 cases total. But when we go to the private hospitals, they're having a lot of cases. So for example, close to us is Nairobi Hospital, where the ICU at some point was full, and they have a lot of cases admitted into the hospital. Some of these are foreigners coming from Tanzania and Comoros and other places, but I guess and also a lot of the other private hospitals have reported a significant number in the hospitalized patients. I don't know what explains this variance. We've looked at, is it our testing rates? And it's really not our testing rates because we're doing significant testing. But in hospital, we've had a few cases. And this now brings me back to that discussion, what Dr. Sood said earlier about closing facilities. In KNH, for example, we had multiple facilities that were being used for management of COVID when the numbers were very high. So now some of them are empty. And of course, the question is, how do you maintain an empty unit? So the administration gut instinct is to close some of these units so that they can deploy staff elsewhere. And whereas that makes sense in the immediate term, the question is always how to quickly mobilize staff and units to respond to any emergencies or any uprise. So even as facilities close or downscale, whatever they have, you must have a plan for quick mobilization, especially if you close ICU contexts, because those are very difficult to mobilize. And that's something that every facility needs to have a plan around, even as you downscale on some of the units. So again, this is data that's summarized by the Emergency Operations Center. It's a little hazy because I took a screenshot of the PDF, but it's really just looking at mortality over time. And the picture sort of remains the same. One, very few mortalities in children, including school-going children, which was a concern as schools were reopening. And then most of the mortalities being seen in the older age groups, particularly in the over 60, and again in the males. And we've discussed this before in terms of the risk factors for severe outcomes of COVID. And I think over time, they've sort of remained the same. Older age, male gender, and patients with comorbidities, particularly diabetes. And the reason I mention this is these are the patients you really have to think about how to risk stratify and how to optimize their care when they come into hospital. So now we've received a lot of questions, and we keep receiving these questions. We've gone over some of this in the past. But again, just to remind us, because as we begin to see maybe slightly more cases, these questions will keep coming up. So the first case scenario is where a colleague calls for your advice, and they say they managed a patient yesterday, and they've just been informed that this patient has tested positive for COVID-19. You know what, for us as healthcare workers, we do, you immediately want to be tested, you're panicking, you want to leave work, you want to go and stay at home. But what then do you advise someone like this? So ideally, one of the things you want to know is what sort of exposure was this? What PPE did this person have? So if someone had an N95 mask and was seated, apart from the patient, maybe a meter or 1.5 meters, then they really do not need to do anything more because the risk of significant contact is limited. If they had a surgical or medical mask and were with this person for less than 10 minutes, again, the risk of significant contact is limited, and they probably do not need to do anything beyond that. The question around time to testing, because again, healthcare workers, we've had that habit of we have contact today, and by evening we are knocking on doors, we want a test immediately. Remember, viral shedding does not occur until probably 48 to 7 days after the exposure. So having a test on the day of contact does not make sense. Even the day after the contact does not make sense. Many times we probably advise this person to quarantine, stay at home if they've had contact, and only test if they develop symptoms or after 7 to 10 days, or whichever comes first, as opposed to rushing to test every other day. Okay, this one is good for for discipleship or stewardship of resources that we have. If they develop symptoms, then at that point you would want to test. Okay. So I look at a second case scenario where a neighbor calls that he has been feeling a little under the weather, and 2 days ago got a mild sore throat. A COVID test done at work was positive. And the question is, what should he do? So again, thinking back, he now has COVID. Clearly, he has been going to work. And we know that viral shedding will start maybe a day or two even before onset of symptoms. So which means if he's been at work, he's probably been shedding virus for 3-4 days, which means if you're thinking about contacts for this person, you want to go back a couple of days and think around, where did he have significant contact? So it's not everyone in the building. I remember in the past, we've seen buildings closed because one person was found to have COVID. So it's not everyone in the building. It's really who has had significant contact. Maybe the person with whom they share an office, because when we get comfortable with people, we tend to remove our masks after a while, or, common points where like tea rooms or where they have their lunch and they have contact with other people, because often the masks are off. So you want to look for who are the significant contacts so that you can think about quarantine and testing if they develop symptoms. Then, of course, the question around where should he be managed? He says he had a mild sore throat. So in the absence of other symptoms, you want to look at what his risk for severe outcomes would be. What's the age? What comorbidities does he have? Are you able to get an oxygen saturation, for example? And if you don't find that this person is at significant risk for severe outcomes, then this is someone who can be managed on home isolation. And typically the duration would be 10 days from the day of the test, and they need to be symptom-free at the time of the isolation. They don't necessarily need to retest. And this is a question that often comes up, that where can I go for retesting? They don't necessarily need to retest, because at that point, because we've discussed this before, the risk of transmission is low after several days. So retesting is really for the person's comfort rather than for any public health input in this particular case. But the one that comes up most is, what should I take? That's always the next question. Okay, I'm at home, what should I take? And it's interesting that recently we're seeing a lot of odd remedies. We have people taking ivermectin at home. There are some who are still taking hydroxychloroquine. Some are taking all manner of steroid prescriptions. People are taking antibiotics, azithromycin, then they take Zinacef, then they take, all manner of things. And the question is, what actually will work and what will reduce? Why would you want a prescription? There are two things. Does it reduce symptoms? If someone has mild symptoms, and they probably don't need anything, does it reduce viral shedding? And with that, does it reduce transmission? The other very common prescription we've seen is vitamin C, zinc, vitamin D. What else do you see? Those are the main ones. So I just wanted to share with you 2 recent papers that have been published looking at vitamin C and zinc, because those are probably the most common. Everyone has stocked up on a lot of vitamin prescriptions. So this is an interesting one, and it just gives a summary. And it's the effect of high-dose zinc and ascorbic acid supplementation versus usual care on symptom length and reduction of symptoms among ambulatory patients, so patients who are managed at home, okay? So about just over 200 patients who had confirmed COVID-19 and were being managed at home. It was randomized but open label in hospitals in a sort of one system in Ohio and Florida. And they randomized this patient on a factorial basis, 1:1 to 1:1. To either standard of care, so they did not get any prescription for specifically for the viral illness other than their usual treatments, or to vitamin C, or to zinc, or to a combination of zinc and vitamin C. And the main outpoint was the number of days required to get a sort of 50% reduction in symptoms, so that they feel about halfway there to full health. So severity of fever, amount of cough, fatigue, and the rest. And they followed up these patients. And basically, what they found was that there was absolutely no difference in duration of time to 50% or duration of symptom reduction between any of the arms. So basically, these things may not be harmful, but they actually do not help. So many times people are asking for some prescription. Even as you give what you think may not be harmful, remember, you want to see, am I doing good to this patient? Am I doing no harm to this patient? And this was, I think, a very interesting study because it answered a very, very common question. The issue of vitamin C has also been explored in patients who are critically ill. And the question was, if you give very high dose vitamin C, and the basis of this is that a lot of these viral infections are associated with oxidative stress, and things that like vitamin C will reduce this oxidative stress and may improve care. And this particular study, it was a small study, but it was actually a randomized clinical trial that either looked at giving patients placebo or high dose IV vitamin C. And some of the things they were looking at was days off of mechanical ventilation. They looked at days off of, I think they also looked at mortality, but the main thing was invasive mechanical ventilation. And basically what they found was that there was no difference between these two groups. So when in patients who you admit into hospital, adding high dose vitamin C to their therapy does not seem to change outcomes. Given that this was a small study, they just enrolled about 50-something patients, then they controlled, this was in China, so the outbreak was controlled and they couldn't enroll more patients. But the data we have so far, that when this high dose IV or other high dose vitamin C in critically ill patients does not seem to make much of a difference. Okay, so the next case scenario is a 56-year-old male who presents with one history of cough, has some difficulty breathing with activity. He's had a positive COVID-19 test, and he also has had a HRCT that shows ground glass opacities involving more than 50% of the lung field. So this is someone who has, moderate to severe disease. His oxygen saturation is 87%. So now that tells us that this man has severe disease. So what is next in his care? These are probably the ones that will come to us in hospital. So we really have to think logically about what are we going to give these patients. So one, what further history do we want? So here you really want to be able to tell these patients risk. Okay, knowing the risk, I think just, I'm not sure it changes your management, but it probably helps you to think, where am I going to manage this patient? This patient has high risk of deterioration. So I have to be able to think, if oxygen alone doesn't do it, do I have other means of non-invasive mechanical ventilation? And if that doesn't work, what else can I offer this patient? So it helps in sort of planning and discussing the treatment options with the patient. Of course, other history you'd want to know about who his contacts are and how to take care of those contacts. And just to go back a step, in finding out about what his risk factors are, we'd already mentioned this. So we know his age. How old was my patient? 56. He's a little older, but is he diabetic? Is he hypertensive? Does he have cardiovascular disease? Does he have a chronic lung disease? Those would be relevant. Does he have significant immune suppression? Are there other medications that he may be on? So that's history that you want to get for this patient. Of course, the next question is, this patient has a saturation of 87%. How are we going to deliver oxygen? And I guess even for the units that are already thinking about closing or downscaling to some degree, you have to think, if you got a sick patient, how will you manage them? Do you have oxygen? Do you have flowing oxygen, not just cylinders? And I hope by now every county has piped oxygen or bulk oxygen, or Thuranira is shaking his head. Maybe counties can tell us in the chat box what capacity they have in their counties. But hopefully we took advantage of COVID last year to upgrade our facilities. So do you have oxygen in that facility? And how would you deliver it? Do you have nasal prongs? Do you have masks? Do you have non-rebreather masks? Is there access to high flow nasal cannula? And you have the NIV masks, for example. So even as you downgrade, these are things that should be available in the facility for care of any patient who presents with severe illness. For a patient like this who has, if you're struggling to oxygenate them with little oxygen via nasal prongs, are you able to prone them? And then, of course, the next question is what medication, and we will come to that. I think I've shown this slide very many times in the previous webinars, but basically just showing the issue of proning and how that works. I have to say that from experience, many patients do not tolerate proning very well, especially if they're on the bigger side. It's uncomfortable and the patient ends up turning and tossing. So really you have to think, is the patient able to tolerate it, and what can you do with your bed and with pillows to ensure that they are prone, because that often will improve oxygenation, at least to a little degree. So what other treatments can we give this patient? So he's coming forgive me for going ahead. There's one thing I wanted to comment about, the issue of what are the relevant labs, even before we go to the management. So if you have a patient like this, you'd want some chest imaging, for example. You'd want to know his blood sugars. You'd want to know about his organ function. So we've seen patients who present with renal insufficiency, and Dr. Sood has previously given a talk on renal issues with COVID-19. So that's something that you'd want to know. You may want to know the liver function test, and mainly because we've noted that patients who have a transaminitis, an elevation in LT and ST, often have more severe outcomes than patients who do not have a transaminitis. Often people have done a CRP, and a high CRP is associated with worse outcomes. But the reason I say you may do it is because they really do not change how you will manage your patient. So if you have limited resources, do not be struggling to do labs that may not change what you do. Many of the labs with a lot of resources end up doing ferritin and D-dimers. A D-dimer may be of some use, especially in terms of stratifying your patients as to how much anticoagulation to give. But generally, some of the just very basic tests will be sufficient to help manage these patients. A blood count, again, often done. And the main thing we've noted with COVID-19 is that severe lymphopenia may be associated with worse outcomes. So in terms of risk stratifying, those are some of the labs that may be useful. Okay, so then the question is, what do we give this patient? We've given them oxygen, we've tried to prone them, what next? So there's a question of steroids. And I'll give steroids a bit of emphasis for two reasons. One, we've noted a lot of people are taking steroids at home. People have stocked up on steroids, people are popping prednisone and dexamethasone and the other things. And we know that steroids may be useful in a certain subset of patients. And this really just looks at what stage is steroids useful, and then how are they useful. So if you think about someone who has early initial symptoms, we know there's viral replication most rapid just before onset of symptoms. It peaks very early in disease, then it begins to go down. Disease progression, on the other hand, may go beyond the period of viral shedding, okay? And these are some of the tests we talked about, the D-dimers and the CRP and the rest. So what then will steroids do? So some of the things we note with this, what is known as the inflammatory phase of COVID-19, that's beyond the viral replication phase, is that you'll have an increase in certain pro-inflammatory markers. So you'll have an increase in things like interleukin 10, you'll have an increase in certain markers, but a reduction in some of the anti-inflammatory markers. And really what steroids are coming to do is to modulate the immune response, not to suppress the immune response, but to modulate this immune response. So we'll just again mention a few studies. Some of this we've mentioned in the past. So one, like the recovery study that recruited quite a large number of participants and randomize them either to receive dexamethasone or usual care without dexamethasone. And basically what they showed was that dexamethasone in patients who are receiving invasive mechanical ventilation, so that's the chart to the bottom right, was associated with a decline in mortality by close to about 30%. So if a patient requires mechanical ventilation, we definitely will give dexamethasone. If a patient requires oxygen only, then the reduction is just about, what is 1/5? About 20% or just below 20%. So again, in patients who require oxygen, we will give dexamethasone. In patients who do not require oxygen, there was a trend towards higher mortality if they receive dexamethasone, which means it's someone who you're managing at home, those people who call you, the neighbors and the colleagues and others who call you and are at home with normal oxygen saturation, they must not be on dexamethasone. The increased risk of side effects of steroid use, gastritis, increase in blood sugars and the rest, but they also increase the risk of more severe outcomes, okay? So I'll jump that on. There are also a few other studies that have looked, like this is called the REACT working group, which is the WHO put together a lot of studies looking at steroids. And again, basically what they showed is that steroid therapy is useful in patients with severe disease as compared to no steroid therapy. And sort of this is what this chart shows. To the left, favor steroids, and to the right does not favor steroids. So for most of them, they favored steroids. Looking at the dose of steroids that were used in most of this, in the recovery, it was 6 milligrams per day. A few of them used slightly higher doses, and some of the ones that used high doses did not necessarily show any impact on outcome. The reason I mention this is that recently we've also had a trend towards people wanting to use high doses in patients who are hospitalized, because I think that will suppress this immunity even more than the low dose. But remember, we said the aim is not to suppress immunity, but to modulate the immune system. Okay, so here again, looking at different subgroups in now the REACT meta-analysis. Basically, patients who require invasive mechanical ventilation, patients who require oxygen treatment are the ones who are most likely to benefit. Okay. And basically, REACT showed that administering low dose of corticosteroids was associated with a reduction in mortality, basically. Okay. So I'll just mention a little about high-dose steroids. Do we have any data to inform high-dose steroids? As we've seen from this one, most of the studies use lower doses of steroids, 6 milligrams per kilo in the recovery trial. So this is one particular study that looked at patients who are either given standard dose steroids or high-dose steroids to look at the outcomes. And basically what they showed was that high-dose steroids, especially in older patients, were associated with worse outcomes. So higher mortality in patients who had high-dose steroids, especially with older age. So basically, we do not have clear evidence to use higher doses of steroids in patients who have acute COVID-19. In discussion with some of our colleagues who are pulmonologists, there's always this feeling that for patients who have an organizing pneumonia on their scan and continue to require high amounts of oxygen, there may be a role for higher dose steroids. And this is because organizing pneumonia outside of COVID is managed with high dose steroids. But as at now, we do not have evidence for that strategy. Okay, so just to summarize that, higher dose steroids were associated with higher mortality. And even if you look at issues around severe ARDS, there's really no difference in progression to severe ARDS between low dose and high dose steroids. So again, we are modulating, we are not suppressing the immunity of the patient. A few other drugs that I'll just mention briefly. So one, we've said this patient, we are proning him, we're giving him oxygen, we're proning him, we're giving him low dose of steroids. Okay, so going back to the Solidarity trial from the WHO, most of the study arms have been stopped. We'd hoped to join this trial, but every time as we got ready, one study drug was dropped because there was evidence from other countries. So hopefully we'll still get other study drugs going forward. But this again was a randomized patient, so patients are either randomized remdesivir, hydroxychloroquine, lopinavir, ritonavir, interferon beta-1a, or standard of care. And looking at the various arms, again, with hydroxychloroquine, there was no benefit. With remdesivir in this particular study, they did not show any benefit. Lopinavir, ritonavir, again, showed no benefit, neither did interferon beta-1a, where there was a tendency towards slightly worse outcomes. And the outcome of interest here was mortality. Okay. So basically, just to summarize those, hydroxychloroquine, not useful. So those who are taking hydroxychloroquine at home should stop. Remdesivir in Solidarity did not appear to reduce severe outcomes. Neither did lopinavir, ritonavir, and with interferon beta-1a, there was actually a tendency towards worse outcomes. Remdesivir is one that's interesting because there seems to be a lot of demand. I think more because it has been marketed aggressively in the Kenyan market. So there's still a lot of questions about remdesivir. And whereas other studies have shown some benefit, some of the largest studies to date have not really shown us much benefit. And this was a meta-analysis carried out by the WHO Solidarity Trial Consortium, looking at various studies and looking at are there particular groups that you can clearly show that there is benefit. And basically at the end of the day, looking at all the groups, they didn't seem to show significant benefit in any particular population. As you can see, for most of this, the cross-nullity, and there was not a single group that was identified clearly in which there was benefit. Having said that, there's some studies that have shown some benefit, and consideration may be given to patients who present very early in disease. Remember, remdesivir is an antiviral, and if we look at this diagram that I'd shown earlier, sorry, I'm trying to find it back here, it would be useful in the phase of viral replication rather than in the inflammatory response phase. So if it's going to be used, it needs to be used early in disease. Okay, so I just have to finish so that I can give Dr. Maritim a chance to present as well. So for this patient, we've given them steroids, we've given them oxygen, we've pruned them. Remdesivir, we felt that they came a bit late and then unlikely to benefit, and we looked at the data and maybe they won't benefit so much. And now there's the issue of, do we need to anticoagulate them? So we've discussed the issues around anticoagulation previously. All patients who are admitted generally should be given prophylactic anticoagulation doses. The discussion that has come up more in the recent past is whether there are groups that we should do therapeutic anticoagulation or whether we should give prophylactic anticoagulation in all groups. The underlying principle is that COVID-19, one, is an inflammatory response, may cause a vasculitis because, as you remember, SARS-CoV-2 binds to ACE inhibitors, which are very highly concentrated in vascular endothelium. So endothelial cells may get infected and you end up with a vasculitis. So those are questions that that's the underlying principle behind the issue of requiring anticoagulation. So there are some studies that have looked at what anticoagulation should we give. Is it treatment dose? Is it prophylactic dose? And I'll just share, I think, one or two of this. So this, again, many studies on anticoagulation have been retrospective. So of course, there may be some methodological issues that may interfere with the results. But basically, this was a single center retrospective study that compared survival with treatment dose versus prophylactic dose or no anticoagulation. So here is a therapeutic dose and no. When I say here, I'm hoping people see my cursor. Can you see my cursor? Oh, okay, you can see my cursor. Okay. So again, looking at in-hospital mortality in those who were mechanically ventilated as well. And the thought was that there seemed to be a tendency towards lower mortality in those who had therapeutic dose anticoagulation. So this is one study that showed that maybe therapeutic anticoagulation, especially in patients who required mechanical ventilation, may be a little better. Then there are others also, again, as I said, many of these tend to be retrospective, that looked at, again, prophylactic versus therapeutic doses. And for this particular one, there seem to be better outcomes with prophylactic as opposed to therapeutic doses. There are a few studies coming up that are probably a little better because they are prospective, some randomized, that may give us a bit of data. Some of the preliminary analysis have shown that one, therapeutic anticoagulation in patients who are severely ill did not improve outcomes. So they actually stopped enrolling patients who are critically ill. On the flip side, in patients who are moderately ill, therapeutic anticoagulation seem to show some benefit. So again, the data is neither here nor there, and we'll have to wait to see what happens. Dr. Nyurkuri just asked me a question about the need for anticoagulation post-discharge, and I have answered to that question. Some of the observations we've had is we've had patients who went home and came back with PE. And I remember a colleague telling me they had patients who come back with mesenteric thrombosis. So I think it's not, we can't have one guideline that covers everyone. I think in certain patients, you may need a case-by-case judgment where you weigh the risk of anticoagulation in terms of bleeding and the benefits of the same. So in a patient who's going home and is going to be up and about, you may need. Okay, so in patient. Sorry. Okay, so in this, I think in those circumstances, you need to weigh. A patient who's going to be up and about, going home, may need less of continued anticoagulation, as opposed to a patient who has multiple other risk factors for clotting and may not be up and about. This is something that evidence is evolving around, and we may find new data as time goes on. And in those particular patients who are at highest risk, you may need to do a case-by-case analysis. Okay, almost done. One of the things we've asked, and I told the people at home are taking ivermectin, is ivermectin working? I don't know. There's been such a push for ivermectin. It's amazing. But there've been a lot of evidence review around many of the studies that have shown ivermectin works. One, many of them have had methodological flaws, so that you really have to read and judge what's happening. Many organizations have reviewed this data. So one, starting with the manufacturers of ivermectin, which is Merck, that say they've reviewed all the data and they find no evidence or any reason why ivermectin should work. You'd think they would promote it because it will bring them money, but they actually said, no, it doesn't seem to work. The WHO has not released a specific statement, but again, from a lot of the literature review, there's really no strong evidence to indicate that ivermectin will work. Some organizations like the FDA have said, well, we don't have enough data to say whether it's useful or harmful, so they've left it up to people to decide. So at this point, we do not have enough data to suggest ivermectin will be useful. Antibiotics, because they're very commonly given, data has shown that the risk of co-infection between COVID and another bacterial infection is very low. So ideally avoid antibiotics in these patients unless you have strong reason to think that there's a bacterial infection, and only start antibiotics once you've taken sufficient samples for culture. Okay, as we mentioned before, hydroxychloroquine does not seem to work. So going back to our patient, we will give him oxygen, we will prone him, we'll give him prophylactic Clexane, and we'll give him low-dose steroids. And then we'll hope he does well. Thank you very much. I know I've talked a lot, but allow me to stop there. The other question that has come to us a lot is about vaccination. Many of our patients who come to clinics because of HIV and something else ask, is it okay for people like us? And of course, there are those who've said this is a conspiracy theory. And of course, there are those of us who are pushing government to bring this vaccine now. So we need to just know a little more about these vaccines. What do we expect? When do we expect? What are the challenges we're likely to experience? And we're very happy to have Dr. Maritim with us today, and she'll come up next and we'll just look around at the issues of vaccination. Okay, she's untangling her earphones, so give her 1 minute. And if you have any questions, please post them on the Q&A. If you have any comments, if you have any lessons you've learned from managing in your own facilities, please share those lessons. Every time we're thinking about what is relevant for the next presentation. So if you have questions, areas that are still not very clear that you'd like us to handle in the next webinar, please feel free to send them and we'll try to get the evidence and talk about it in the next presentation. Okay, Dr. Maritim, you ready? Karibu.
Good morning. Okay, good morning, everyone. Thank you so much for this opportunity to share a little bit about the COVID-19 vaccines. So we started this vaccine discussion last year, and the government is planning a rollout, and the healthcare workers will be included in phase 1 of that vaccine rollout. So this talk is really to prepare as healthcare workers to receive the vaccine and not focusing so much on how to administer the vaccine, but just giving a brief outline of the vaccine. So not speaking as a government official, but just what is it that we need to know to help us accept this vaccine when it's available. I hope I'll be fast on the queue. For those people who will be giving, just make sure I'm fast on the queue. So this is the outline of my presentation, just to give a brief summary of the COVID-19 vaccines that are available. Look at the global doses that are administered, because by looking at this, it really helps us to understand the safety that is there and what maybe the severe adverse reactions that may be associated with the vaccine and how to mitigate against this. We'll also look at the vaccine safety in generally. and look at efficacy and effectiveness, and then how do we prepare ourselves as vaccinees to receive this vaccine. So it's a fairly short presentation. So this table is really summarizing a lot of the detail, and Prof. Anzala mentioned some of this detail in great detail last year when he talked about the vaccine. But basically, we have different vaccine constructs. The ones that are very advanced are the first two. These are RNA-based vaccines, and they are mRNA encoding for the spike protein in different doses. The Pfizer vaccine is 30 micrograms, while the Mrna vaccine is 100 micrograms. And these are the actual name. People know the vaccines by the name of the manufacturer. So the first one is the biotech Pfizer, and it has that number that they use in the clinical trials. And then we have the Mrna. So in our part of the world, it's very unlikely that we may receive any doses of the Mrna, because this has largely been taken up in the American market. So it may not even be feasible to receive some of this, because it's the one that requires very cold temperatures for transportation. So in terms of the dosing, currently available vaccines, none of this vaccine is oral. All of them will require intramuscular injection, mainly 2 doses, but we have the new one from the Janssen that will only require 1 dose. So when you're looking at the administration, we need to prepare ourselves muscular injection, and it's currently dosed at 2 doses at day 0 and day 21. So for the and 28 days apart for the Mrna. And when you look at all these vaccines, none of them has received approval, total approval for use and marketing. What we have is a preliminary approval that's called emergency use authorization, where the vaccines are being used in the setting of pandemic, because we don't have full data that is required for full licensure by regulatory authorities, including the FDA. So currently what is available is emergency use authorization under FDA, and WHO, they call it emergency use listing. So this last column here is very busy, but I've highlighted in red the things I wanted to focus on. So when you talk of excipients, it may include the things that are used to package the vaccine and constitute the vaccine so that it's even able to be administered, transported, preserved, and all those things. So of interest is the polyethylene glycol 2000 PEG, which is common for the mRNA vaccine. And I believe it helps the vaccine to remain stable even in the cold temperatures under which it is stored. And we have previous experience where pegylated or pegylation has been used, for example, for some of the pegylated interferons that have been used in hepatitis B treatment in the past. So this is it's not really a new compound or molecule that's being used, but has been used before. But we'll talk about this because it's what has been, the severe anaphylaxis has been attributed to this polyethylene glycol as a preservative in these 2 vaccines. However, when we look now at the vaccines that are likely to come to our part of the world, which are mainly the adenovirus vector, non-replicating vector vaccines, of which we have 2. The second one having just received the FDA emergency use authorization this week, I think about 3 days ago. So we have the Chadox vaccine, which basically has a non-replicating chimpanzee adenovirus 5 expressing the spike protein, developed by AstraZeneca and Oxford University, again, intramuscular. And then we have the adenovirus non-replicating AD26 vectored vaccine, with all those other name terminology, again made by Janssen. So these 2 vaccines are to be administered intramuscularly. The AstraZeneca vaccine will be administered 2 doses, 28 days apart. So a bit similar to the Mrna vaccine. For the Janssen vaccine, this is just, I think, one of the first vaccines that will be given as 1 dose intramuscularly. So for these 2 vaccines, the AstraZeneca and the Janssen, they're a bit behind. They are still in phase 3 clinical trials where they're trying to gather a lot of data. But you know that there will be a lot of overlap between phase 3 and the emergency use authorization because they've already received that. So we'll have the phases being phase 3 and 3, maybe 3A. But for these vaccines, these 2 vaccines, the adenovirus vectored vaccines, There are of interest is the polysorbate 80, which is one of the excipients within the vaccine, and has been where the anaphylaxis has been reported. This is actually what it has been attributed to mainly. So looking at it, it's unlikely that these vaccines can be modified, and therefore, even as we look around this, countries where they're administering, they'll need to collect the data of people who have anaphylactic reaction, which is really a severe form of the adverse event, and it's what is called adverse event of special interest as part of the short-term safety concerns. I don't want to talk too much more about the two remaining vaccines because they are still fairly behind in terms of clinical trials and have not yet even been approved for emergency use listing. So we'll skip those two. So in terms of how many doses of vaccines have been administered globally, and there's been a recent debate about equity and equality because the developing world has really lagged behind. And the main concern is that even for developed world that are protecting themselves, they'll never be entirely safe until all the world is really protected. And this is where the COVAX facility comes in, because it has tried to balance that. And even when it was being established, it was really to allow some fairness and equity and access, because these vaccines cost money. And what the developed world did, they sponsored a lot of this pharma to expedite the R&D, and therefore they provided resources for the development of these vaccines through an advanced market commitment strategy where they put in a lot of the money. And therefore, when the vaccines were available, they were the ones to receive. And looking at this data, we see that United States has received, a lot of the vaccines have been administered in that country. However, what this data shows is really about the total doses rather than the number of individuals who are vaccinated, because like we've seen in the previous slide, you need 2 doses to be vaccinated. So this doesn't show too well because there's so much crowding of these other countries, but this is a better illustration where we see the amount of doses in the US, about 66.46 million. China, again, 4.52 million. And I'll show you the doses or the vaccines where this, the kind of vaccines which are being used in this country, because China has developed its own vaccine that is being used in its country, but is not yet one of the WHO, has not received a lot of wide use because of the regulatory requirements in various settings. And I know they are really at trying to get the vaccine out there. We'll see the various vaccines in some of these countries. Again, looking at the European Union, the United Kingdom, India, Israel, and Turkey. And in this graph, we don't see any African country. Somewhere along, when you look at the data, this is also sourced from World Data. And when you look at the countries, South Africa ranks somewhere at the bottom, but it's because of the clinical trial that they were undertaking using the AstraZeneca. So a lot of our part of the world, other than Morocco, we have not really started vaccination to the wider population. But we know Ghana has been the first country that received its vaccine under the COVAX facility. So this is just a summary of, again, from our World Data, looking at the various antigens being used in the different countries. And the importance of this is really to help us to see the safety signals, because some of these vaccines, when you're doing the clinical trials, you're using a smaller population of about 20,000. But when you're given 66 million doses, you can actually be able to see things that were not picked up in the clinical trials, because now you're vaccinating a wider group of the population. So in the US, using mainly Moderna and Pfizer vaccine. In China, using Sinopharm from Beijing, Sinopharm from Wuhan, and Sinovac. And this vaccine has actually been used in some of the other countries that are close to China in the Asian subcontinent. UK, again, using Oxford AstraZeneca and a bit of the Pfizer. India using Covaxin and Oxford AstraZeneca. I need to find out what Covaxin is, but I think it's the Oxford AstraZeneca, maybe made by the Serum Institute. Israel, and I'll talk about a little bit more about Israel because it has provided a lot of data that's really useful for go after others have been before us. So using Moderna and a little bit more of the Pfizer vaccine. Turkey using Sinovac, and then Brazil using Oxford AstraZeneca and Sinovac. So Sinovac, again, being used and available for use in a lot of the developing world, but we need more data. For many of us who sit in advisory groups, we need a lot of data to scrutinize some of these vaccine antigens, even as we make the decisions. So again, looking at cumulative doses administered per 100 people. So in the previous graph that I showed you, we could actually see the number of doses that the US has already administered is fairly very high. When you think of 66 million, if these were doses in Kenya, it means we would have actually vaccinated maybe half the population, because you need 2 doses, so about 33 million people, slightly under, above half the population. But looking at the entire population of the US, this is a drop in the ocean. So when you look at countries that have only given 7.8 million, like Israel, when it comes to this other graph, per 100,000 population, actually Israel is leading because it has vaccinated about 90 people per 100 people in the population. So a very high uptake and reception of the vaccine within that particular area. Again, the United Arab Emirates, again, following closely in that. So this graph is more specific because it tells you about really the access and coverage within a specific group or a specific geographic area. So looking at the vaccine adverse effects, these were some of the symptoms that were noted in the clinical trials. And when you go to the CDC website, it has actually prepared leaflets or information that you can distribute to vaccinees ahead of time, which actually clearly explain what the vaccinee would expect. And this data is often collected from clinical trials. So what we currently have is just short-term data of what do we expect after the vaccination. More data on long-term safety, again, will come in a matter of time as we continue collecting the data. So these are just general vaccine adverse events that you'd expect for a lot of vaccinations, and they are not unique only to COVID-19 vaccines. But even when you get an influenza vaccine, if you get a tetanus vaccine, you have some of these side effects. So injection site pain, tiredness, headache, muscle pain, chills, joint pain, fever, injection site swelling, injection sites redness, nausea, feeling unwell. Sometimes you can get swollen lymph nodes because of the antigen that is being taken up at the point where it's introduced. So these are not very serious adverse events. And most often you'd advise the person to take, for example, if they have pain, they'll take some analgesic. If they have pain and fever, again, analgesic with antipyretic activity. So you manage this symptomatically. However, the concern has been because of the mRNA vaccines and the pegylation process. And this schema is just illustrating how the mRNA vaccine appears or would look like. So you have the lipid nanoparticle, which has the mRNA within it. And it has this pegylation to make it stable as it is introduced. And we talked about giving it intramuscularly. So when you inject it and it goes, it's able to go to the target cells, which are mainly the immune cells, where the encoded mRNA is exposed. The mRNA enters the ribosomes, which are part of the rough endoplasmic reticulum. This is biology. I think maybe part year 1 of med school when you're learning physiology, the rough and the smooth endoplasmic reticulum, where protein synthesis occurs in close association with the Golgi apparatus. So once you have the mRNA, which is messenger RNA, carrying the message for transcription of the protein particles that will really are related to the spike protein. So you have that process that eventually results in production of these patient-derived antibodies that are targeted against the spike antibody, and they appear on the cell surface. Whatever is expressed on the cell surface enables the body to, is in the form of antibodies, and which now target the circulating virus. So you basically develop an immune response, which is an antibody-based immune response. So when you're looking at the vaccine reactions, you characterize them either as immediate or delayed. So some of these immediate and delayed would take some time, and some of them would be the manifestations of what you've already talked about, the pain at the local site and things like that. So you have the delayed ones, which can be site reactions. You can have urticaria, serum sickness, fever, rare skin, and organ neurological sequelae. So this delayed form would really, some of them would contribute to some manifestations that the patient may develop thereafter. And this would be important to keep track, so that even when you vaccinate someone, you want to keep a record. If they have symptoms, you have to have a toll number where people can call or they can communicate with the health facility and be able to report some of these adverse events, because some of them may now be seen when you're deploying the vaccine to a larger population. So the most important thing really as part of adverse event surveillance following the immunization would be to follow this algorithm where you want to recognize and offer acute treatment. So you look at the symptoms and signs and provide a clinical phenotype of the person. So in some patients have allergic tendencies, and we'll talk about some of the contraindications, particularly for the Pfizer vaccine. So you have a provisional clinical phenotype and take a detailed history and do clinical causality assessment. So in the clinical history, you want to document if the person has clinical history, either allergy to a vaccine component or is predisposed to other allergies based on the history. So if there's family history of atopy. You want to find out if there could have been other drugs that the patient may have taken before the vaccination, because this is important. Some of these can act as epitopes that now exacerbate the immune response. You want to do a physical exam and document a clinical phenotype. And in settings where resources allow, you can actually do allergy assessment and testing. In our setting, we may not be able to do a lot of this sophisticated testing. But as part of the National Vaccine Safety Committee, when we have a suspected case of a severe adverse event, then we have to follow this algorithm in terms of evaluating the patient. You can do ancillary lab assessment, again, very sophisticated tests where you want to document allergy. And I believe this is what has been done for the few cases where patients have developed an anaphylactic reaction, to really try and characterize what is it that could have contributed to the allergic or the severe adverse event that is of special interest. And then mechanistic assessment. So you combine all the clinical and the lab information to help and revise and document the clinical phenotype. Because in the end of your causality assessment, you have to classify the adverse event and say whether it's really vaccine related, vaccine product related, is it because of hysteria or other things. There are 5 classifications that we've talked about previously. And then implications for safe vaccination and future management. Again, on the individual patient, you can rechallenge with vaccines with alternative constructs. So if somebody reacted to an mRNA vaccine, and we've seen both of them have the polyethyl glycol, you may not rechallenge with that, but you may offer them another vaccine that doesn't have the polyethyl glycol. So maybe the adenovirus related vaccines, and then determine implications for reactions to other vaccines. So this data is what will really help us to try and clarify and say what exactly explains the severe adverse reactions, which are mainly the anaphylaxis. So there's a remote chance. This has been documented for the Pfizer and a few cases of the Moderna. And this I picked from the vaccine information insert for the Pfizer vaccine that's been developed by CDC. So I just focused on the Pfizer vaccine because I feel like this vaccine may come to our jurisdiction and we may have a chance to administer it. Moderna, again, has its own specific sheet, but some of this information is shared. So a severe allergic reaction would usually occur within a few minutes to 1 hour after getting a dose of the Pfizer. And therefore, for certain patients who give a history of allergy, you have to observe them for up to 30 minutes after administering the vaccines. And what you'll be looking out for are difficulty in breathing, swelling of the face and throat, a fast heartbeat, a body rash all over, dizziness and weakness. So you're not just watching the patient, you have to be ready with your epinephrine and other things to resuscitate the patient should the patient develop anaphylaxis. So your aim if you're the one administering the vaccine, it's not just to observe, but you are actively trying to prevent and avert a mortality. So talking about vaccine efficacy and effectiveness, when you talk of efficacy, this is what is generated, the data that's generated, the protection data that's generated from a clinical trial under observation. So for the Oxford AstraZeneca vaccine, it's about 62 to 90%. For the Mrna vaccine, 95%, and for the Pfizer vaccine, 95%. So a good way of remembering is that your RNA vaccines have a very high efficacy. Your adenovirus vaccines have a lower, slightly lower efficacy, but they're still useful. So this data was published 2 days ago, and it's really a very nice paper, and hopefully maybe you can discuss it at length in a future journal club or through this forum. So this is really looking at effectiveness. When you talk of effectiveness, this is at a population setting. So this is data from Israel, which looked at the safety of the Pfizer vaccine in a nationwide mass vaccination setting, and they wanted to share data on effectiveness. So when you're talking about effectiveness, is how many people are protected in a setting that's not controlled, like in a clinical trial, so at a population level. So this, they use data from health services. It's called Clalit Health Services. And this health service insures 4.7 million patients in Israel. So a very high number of patients. And in this health service, they actually have very detailed data. It's a database that has data going back up to 2 decades of worth of data. And they have this group of people who go regularly to receive healthcare and have regular parameters. So I'll mention the study period, but they included all these people, 16 years, no prior COVID before, and then you have to have been a member. And in the data, they excluded people who were not part of this scheme, or people who lacked some form of data. So the study period was from the time they rolled out the vaccine, from December 20th to February 1st, 2021. And they included all newly vaccinated persons who were matched in a ratio 1:1 to unvaccinated controls. And for this particular paper, they were focused on trying to look at other endpoints that other previous data sets had failed to do. Remember, a few weeks ago, I think last week, we had, after the South African terminated the use of the AstraZeneca, in that paper, or the summary from the Africa CDC, the population that you expected the worst outcomes had actually not been included in the vaccine trial. And therefore, it's like the validity of those findings could not have been provided by the population that had been vaccinated. So in this particular paper, they went out of their way to document or provide data for a younger population and included other people who had comorbidities. So the older people were actually less represented in this paper, because we already knew from other sources that older people are likely to have bad outcomes and therefore would benefit the most from clinical trial. So for each person, follow-up ended at the earliest of this: occurrence of an outcome event, death unrelated to COVID vaccination, vaccination of the matched control, or end of the study period. So some people were controls at the beginning, but they ended up being vaccinated. So this is just a flow chart. They started off with about 3 million people, all of them meeting the inclusion criteria I've talked about. They excluded certain people who are likely to already be overrepresented in one arm. So healthcare workers, people in a nursing home, people who had interacted with a healthcare setting within 3 days, people who did not have some other data that they were interested. So in the end, they were left with about 600,000 people who are included in the vaccinated cohort and unvaccinated cohort. And therefore, we have data from 600 people who received the vaccine to try and see whether the vaccine actually protected from different things. So when I looked at this table 1, I was wondering, like, this is so perfect. Everything was matched exactly for the various things, but it's because they have this database and they could get exactly the people they were looking out for. So when you look at the matching for some of these general parameters, the age, median age, again, we see a younger population, the gender, very well matched, risk factors and things like that. However, when you go to the second part of the table, when now they're looking at other comorbidities, this is now where you see, again, very good matching, because they were able to get these people from the database. So majority of the people had a high BMI, and we know that high BMI is likely to be related to a poor COVID outcome. We had smokers that were similar between the two groups. Type 2 diabetes, again, similar between the two groups. And remember, these are younger people with a median age of about 45. So again, very well matched information. Hypertension, immunosuppression, and other things. So it was a fairly good match between the people who received the vaccine and the ones who did not receive the vaccine. So coming now to the outcomes of interest, I forgot to say what were these outcomes of interest, but there were 5 things they were interested in. And again, this came out after the AstraZeneca study in South Africa, where most of the young people we know are likely to get asymptomatic illness. So why vaccinate the younger people when your outcomes of interest that are important would be maybe severe disease, hospitalization, and death? And we know a lot of our symptomatic may not have that. So they had 5 outcomes. They were interested in documented SARS-CoV-2 infection and symptomatic disease, hospitalization, severe COVID, and death. Death was the final outcome. But what these Kaplan-Meier curves definitely show us, time 0 is when the people received the first dose. And then because they were using the Pfizer vaccine, this is the one that you give 28 days later. But in the literature, they talk that some people actually came for their dose a week earlier, around day 21. So another advantage of this study, observational study, happened when there was a big outbreak of COVID-19 in Israel. And that's why I think these curves are actually separated fairly early. But when you look at the people who are unvaccinated and the ones who are vaccinated, you can actually see there was a documented, there was a benefit in terms of there was protection from documented SARS-CoV-2 infection. And one of the things, because of the database, they were able to know people who had not had SARS-CoV-2 based on a PCR test at the beginning of the vaccination. And anyone who had come to the healthcare setting 3 days before was excluded from that randomization to receive the vaccine. For symptomatic COVID-19 disease, again, there was benefit from vaccination. When you look at COVID-19 hospitalization, again, a marked benefit, and the benefit was more dramatic when people received their second dose of vaccination. So earlier on, after the first dose, there was really no much deviation of the 2 curves, but the benefit was much more after the second dose of vaccination, And again, mortality, a lot of, there was significant benefit from vaccination, even at the population. So this is just a summary of the actual numbers. When you look at protection from the first dose, from documented infection, it was just, the protection was about 46%. But after the second dose, 7 days after the second dose, it rose by double to 92%. When you look at symptomatic illness, moved from 57% to 94%. When you look at hospitalization, it moved from 74% to 87%, and severe disease from 62% to 92%. So when you look at this summary of the efficacy of the effectiveness of the vaccination across the board, it was more than 90%. It was actually between 87 to 95%. So basically mirroring what had been found in the clinical trials, where the efficacy was about close to 95%. So looking in the clinical trial setting where it's a controlled environment, this gives us a lot of hope that the vaccine is fairly efficacious, even in a real world situation. So again, the effectiveness was similar to what has been seen in the randomized clinical trials. The variant that was circulating at that time is B117 variant, but I don't know that this variant is one of the variants of international concern. It's not. So again, we can say that, but from studies that have been done, it suggests that the neutralizing antibodies that are developed to mRNA vaccines are broadly neutralizing antibodies and work against the different variants. This B135 variant, which is the UK variant, was not in Israel at that particular time. So having said that, we know that the vaccine is fairly safe, it is efficacious, it's effective. So what will we need to know as vaccines? I'm almost coming to the end of my talk. We know that these vaccines are being used through an emergency use authorization. So we don't have all the data that we'd want to say that these vaccines are now totally approved. So that's one of the things we have to understand, that even by receiving the vaccine, we'll be contributing to the knowledge that this vaccine is required. It's going to be administered intramuscularly, so 2 doses, 21 or 28 days apart. This is the important detail you need to disclose before the vaccination. And I'm sure the records or the data that the Ministry of Health and the forms that will be designed will have some of this information. We would like to know if anyone has allergies. So if you have allergies, you have to declare. If somebody has a fever, because by the time you're being vaccinated and you have a fever, even that fever can still be COVID-19. If you have a bleeding disorder or on a blood thinner because of the IM injection, if you are immunocompromised or on medications that would affect your immune system. So what has been thought is that patients who are immunocompromised, the 2 doses may not be adequate and there may be a need for an additional dose. But again, this would be important as we collect more data. If you're pregnant or planning to become pregnant, because we don't have all the safety data for pregnancy, but I know for the Pfizer vaccine, there's already a pregnancy registry in settings, and there are clinical trials that have been registered on clinicaltrials.gov to look at safety signals in pregnancy on the baby, as well as even for the mother. If you're breastfeeding, and if you have received another COVID vaccine, which in our setting may not be possible unless someone was in a clinical trial. We've already talked about these adverse events that people can experience, which are not any different from those we've seen in other vaccines. These are the contraindications, particularly for the Pfizer vaccine. If you've had severe allergic reaction after a previous dose, you cannot get the second dose because that would just be like killing the patient. Or if you have severe allergic reaction to any ingredients that are listed on the vaccine, again, many of us may not even have a lot of detail of what are included there, but again, this is information that would be important. So basically, to conclude, we know that the current vaccines that are available are under emergency use authorization. So even when we queue on the line to receive them, that's one of the understandings that will be contributing to additional knowledge. We have short-term data that's available, and this safety data is similar to what we've seen for other vaccine antigens. So we should not be totally worried that we may be getting other additional adverse events that have not already been listed. And then the long-term safety is still being collected. We don't have a lot of that. And I know a lot of people have had concerns about RNA and how it can change your DNA. But I think the evidence and the knowledge that's out there show that these vaccines are fairly safe because it doesn't integrate into the DNA. So thank you very much.
So thank you very much, Dr. Maritim, for that excellent presentation. There are a number of questions that have been posted on the chat, and we'll try to answer some of these questions. Maybe we could handle some of the vaccine. We just have a few minutes, so we'll keep our responses just very short. We can handle some of the vaccine-related questions, and we'll go back to the clinical questions. So someone asks, how long does this vaccine protect, and how often should one get a vaccine?
So for now, we don't have that data about durability. So another thing that I forgot to say, the NEJM actually has a full page, I think a 5-pager of frequently asked questions. And I wish I had the link, but we'll share the link with everyone, all the healthcare workers, so that you can read, because this is one of those questions that's in the frequently asked questions. So really, we don't know the durability of these vaccines, and therefore we don't know when we'll need additional boosters. So as we continue collecting this data and monitoring the immune response, then we might get the data in terms of when should we give the booster, is it lifelong? And even, for example, if somebody maybe was in an area where one strain was circulating, and then now they get these new strains that are of international concern, should they get another booster after another year? Because you can find that one strain overtakes another strain, and therefore you may need to have boosters. So that the answer to that question is currently not known. What we just know is that you need the first 2 doses for now. But as we watch this space, then the data will be more available going forward.
Okay. So thank you very much. I think people need to remember that COVID-19 has only been with us for just over a year. The vaccines have only been in use, whether within clinical trial or real-world settings, for probably just about 9 or so months. So at this point, we can't tell how long they will last. So even once people are vaccinated, it won't be the end of it. We'll still have to keep monitoring for symptoms and for any outbreaks coming thereafter. So there are a lot of concerns about safety, and I think you sort of answered some of the safety questions. These ones came before the presentation. Someone asked about, they've had a rumor that microchips are being inserted into the vaccine. Is it true? Actually, that's how it is phrased. It's phrased in the question.
So I don't know whether it's true that the microchips are being inserted in the vaccine, because microchips are big things. We didn't even see it in the vaccine construct. So as it is now, we cannot really say that the microchips have been inserted in this vaccine. I don't even know, unless they are the polyethyl glycol. I can't fully explain. Even Thuranira and Loice are laughing so loudly here.
No, I think it's a very important question to ask.
This
for
is Anzala, maybe to help.
Because it is our role to educate people. So these are questions, there's been a lot of rumors, a lot of anti-vaxxer videos out there. So it's important that we ask this question so that we are better empowered to answer these questions and to educate the communities that we come from. So Dr. Maritim, thank you for answering that question. Professor Anzala, you want to say something?
Yes.
Professor Anzala, please take a minute to say what you want to say.
Yes, you can hear me.
You may need to unmute.
I've unmuted. You can hear me? Hello, can you hear me?
We can hear you, Prof.
Yes, that issue has come up, and the reason why it's coming up, when they talk about how these vaccines are packaged, they talk about nanoparticle. So when people hear of a nanoparticle, some are thinking that that is where a chip has been inserted. But really a nanoparticle is just a lipid bilayer, which is on the outside, and inside you have the mRNA. So that information is from that issue where I've actually seen people saying that nanoparticle, but actually the nanoparticle is just a liposome which holds the mRNA construct itself, which is actually the coded aspects of the DNA of the DNA. So that is actually what we want healthcare workers to know. And also realize that the HPV vaccine that is currently in use is actually a nanoparticle. So there is the same technology, and that's how most vaccines are going to be developed in the future. Over.
Thank you very much, Professor Anzala. I think there is another question about, actually 2 questions. One, if someone gets vaccinated, will they still need to get a COVID test if traveling? And the second one is, if someone has previously had an infection, do they still need to get vaccinated?
So let me start with the second question because it was in the frequently asked questions, so I read the answer anyway. But this has been because of earlier discussions that we've had. So when you look at previous infection, what we know is that when people get previous or are infected with COVID, they may develop the challenge has been the durability of the antibody response and the protection that is offered from that antibody response, and how long that antibody response lasts has not really been well documented. So when you look at other settings, one of the things when you're vaccinating the patients, you don't have to test them first and confirm the status. But if somebody discloses and they say they had COVID before, what actually has been shown from the clinical trials, like when they analyzed the trials like in the US, they were able to show that when people received 1 dose after a previous infection, that dose that they received actually acted like a booster. So they had already some immune response that was developed by the body in response to the virus. And then the vaccine now acted like a booster. So the aim of the 2 doses for vaccination, the first dose acts as a primer, and the second dose is a booster. So it's a prime boost vaccination strategy. So in people who've had previous COVID, what has actually been shown is that they may only need 1 dose of the vaccine. But currently, the manufacturers still recommend the 2 doses of vaccination. So in situations where you have scarcity, you have very limited resources, and you have a very clear database of who has been infected, for those people, it would be good maybe to enroll them in a clinical trial and monitor them and see the antibody response they develop just after receiving 1 dose. But as per manufacturers' guidelines, they recommend 2 doses of the vaccine. And still related to that, the 2 doses, it's very specified the interval. But what has even been shown is that you can delay your 2nd dose for up to 6 weeks, and it would still act as a booster. So this is where you might have shortages. Like we saw this strategy in the UK. They gave people, they prioritize a 1st dose. But the challenge with that is now when people are ready for the 2nd dose, you can really mess them up if you have run out of stock for those dosing. The first question was related to...
Maybe discussion next time is that there's a lot of interest in the use of monoclonal antibodies. There is development of broadly and highly potent monoclonal antibodies. So the whole issue then is for us to be able to ask where will what role and what would be the appropriate time to be able to use these particular broadly and highly potent neutralizing monoclonal antibodies. So they are moving away from the use of convalescent serum, to the use of this. So I think in the next discussions, maybe that could be the way. And also there is talk about would monoclonal antibodies be of use in pre-exposure, like the individual you presented at the beginning, where you find out that there was significant exposure. Would there be a role for the use of these monoclonal antibodies as a pre-exposure prophylaxis? So maybe that could be a discussion you could actually present. And there are a few publications that are now beginning to come out.
Thank you very much, Professor Nzala. We will ask you to summarize some of the data so you can present to us, and also the discussion around the impact of monoclonal antibodies on emergence of various variants and the issue of using combinations as opposed to single monoclonal antibodies. But we can plan for that at maybe our next webinar. I think, thank you very, Thank you very much. Many people have managed to rejoin. I think I'll just try and talk about the clinical questions. We just have less than 10 minutes before we log off. There are a lot of vaccine-related questions that many people have. And I think as we're just discussing, as we're coming on board, is the issue of vaccine hesitancy, especially amongst healthcare workers. So I don't know, can everyone raise their hand? By a show of hands, I want to see how many people will be on the queue to get vaccinated when the vaccine comes. I see 3, 4, 10. How wengine hamjaona raise hand function? It's right there at the bottom. How many people will be on the queue for vaccination? So it's about 20% so far. Show of hands, how many people will be on the queue?
Yeah, 30.
32, okay. Some people are being convinced by association. Stick around, you may get convinced about getting vaccination. But I mean, basically what you're saying is there's still a lot of hesitation. And I hope for you who have listened to the presentation on vaccine, you can actually go back and begin to influence your circles so that when the vaccine is rolled out, we have as many people being vaccinated. Remember, we're only as safe as the numbers that get vaccinated. If you're to achieve what is called a herd immunity, we'll need probably 70 to 80% of our population vaccinated. So please influence your circles. You can put your hands down. Thank you very much. Okay, so just a few questions as we finish. One was, someone asked that if a patient comes with respiratory symptoms and have a suggestive CT scan but negative COVID-19, how do you manage that? So I don't know if you remember the chart I showed you about what you called the phase of viral replication and the inflammatory phase. You're most likely to pick the virus during the phase of viral replication, which is early on in the disease. Some people will continue to shed for longer and you can pick it longer. So if a patient comes with the typical symptoms and you see typical findings on a scan, then manage that patient as a COVID-19 patient. They may not transmit because they're not shedding. They may not transmit because they're not shedding virus at that point, but you still, these are patients who I would still give the steroids, for example. You know, you want to put them on anticoagulation just because we know if they come later in the disease, they will still have the inflammation and the significant pulmonary involvement, but without having viral shedding. Then there was something about, I didn't totally understand this question, debrief counseling post-COVID-19. This was particularly important early in the onset because there was a lot of stigma, there was a lot of unknown. I guess the more we talk about COVID-19, the more the stigma goes down. Right now, the things you probably want to talk to your patient at the end of their illness is that increasingly we're identifying what we call long COVID, or emerging symptoms of COVID post the acute phase, and patients may continue to feel a bit tired. They may continue to have the loss of taste and loss of smell, and those who have significant lung involvement may continue to have some respiratory difficulty. So it's good that patients are aware of what to expect even after their discharge. We still have to engage our communities a lot so that there is less stigma, and even for people like employers, so that they're not requiring or stigmatizing employees when they go back to work. I think those are the issues that we'll need to discuss. There was one question around, would you do CPR in a patient with COVID-19? I remember when COVID-19 first came, we were all so scared. And we all said, CPR, you will expose yourself, you will do this and that. But I think increasingly over time, we know that when we have adequate PPE, we are probably safe. For every patient, you still need to make clinical judgment. What is the patient's underlying condition? What is the expected outcome? What is the discussion that you've had with the patient and relatives around directives around goals of care? So these are things that have to be discussed with every patient who goes into critical care, so that even as you're making the decisions, you know what the next steps are. But if a patient collapses, you need to do what you can to stabilize that patient. Someone asked about HCQ in the market. Yes, HCQ is still in the market because of things like SLE and other inflammatory conditions. So people are hogging HCQ and denying the patients who actually need it. The very last thing we have, Dr. Nyurkuri has asked a question around management and ending isolation in patients with mutant virus. I don't even know the answer to that question. Maybe Dr. Nyurkuri wants to make a comment on it. So ending isolation, I think one, we do not have enough experience in this context to say that. What is known from other contexts is that one, these patients are more likely to transmit. How long they are likely to transmit is a question that's still not very clear. But having said that, I think after this we'll go and look at the experiences from other contexts, especially South Africa, Brazil, and the UK, and see how they've handled issues of de-isolation and even PPE for those taking care of these patients. So maybe next time when we come, we might have a better answer. Dr. Nyurkuri will tell us the answer to that question. I don't know if there's one, maybe Dr. Maritim, there's something about comments on the videos on social media of people fainting after vaccines, sport team members. Yeah, I think maybe you could comment on that. There's one around, wait, I have to find it. Where is the sports team? Did I make it up? No, there's something, I don't know, maybe I made it up. I thought I saw it. Okay, just answer that one as I look for it.
So the question is around fainting after the vaccination. So when you look at vaccine adverse events following immunization, the fainting has actually been described as type 4 reaction and was even noticed for other antigens, was noticed when adolescents were receiving the HPV vaccine, and even was more pronounced when people are queuing together and seeing another person being injected ahead of them in the queue. By the time their turn comes, then they faint. So it will not be unique to COVID-19 vaccine. And therefore, even when you see a patient fainting, it may be part of the anaphylaxis we talked about, but it may be part of hysteria. So the most important thing is to anticipate that some people may faint when they receive their vaccine, but to prepare to nurse them and keep them comfortable, put them to lie flat, elevate their feet, and basically manage them, make them comfortable following that vaccination. And that's why for certain people, as even they're queuing to receive the vaccine, you have to take adequate history. And someone might say, I've always fainted following my vaccinations, and therefore that's a high-risk person that you'll have to anticipate that. So when we look at the social media, it's really to look at what is being posted there and anticipate that this can happen even in our setup, and look at how to mitigate and make the person comfortable, whoever will be able to faint, but not to assume that everyone then will faint following the immunization. And even when somebody faints, we will not consider that as a severe adverse reaction. It may just be one of the minor ones, but if they meet the criteria now for severe, which leads to hospitalization, hospitalization, death, or prolonged hospitalization or inability to go to work, then they'll meet that threshold. So although we've seen it in social media, sometimes what we see in social media is actually what is posted by the people who are anti-vaxxers, but it should not make us think that we'll all faint when we receive that vaccine. While I'm still speaking, I saw a question on the 65-year-olds, whether there is a plan to vaccinate them, and really there's a plan. So the Ministry of Health has planned vaccination in 3 phases. The first phase will target the healthcare workers, and that's why we are asking for who will raise their hand to be on that queue on that particular day. The second phase is targeting, and the rationale for the healthcare workers is really to mitigate the effect on the health sector so that people can be comfortable going back to their places of work and still continue using PPE and the other things, but feel that the government has considered them and prioritized them and protected them. The second phase will have, and for the healthcare workers, what had been envisaged was that the vaccine would arrive by February, and therefore the vaccine that had been anticipated was the Pfizer vaccine. But as the days go by, we don't know what vaccine will come, and it may just be the AstraZeneca vaccine based on the logistics and the cold chain requirements that are feasible within our setting. The second phase is where now the elderly people, elderly being 55 years and above, and people with comorbidities. So they will definitely have an opportunity to be vaccinated. So yeah, I think we can stop there.
Okay, thank you very much. I think, Duncan, you're sort of clarifying what you say, that about national sports team members who may need to participate in sports in various countries, and maybe we won't answer that now, but it's an important question to think about. I think yesterday there was a news item about the team that was meant to go to Tanzania being stopped from going because of such issues. So that's something to take up and maybe to present even to the committee that's looking at vaccination issues around special groups that may need to be considered. So thank you very much. It's been a very exciting morning today. Thank you for all your questions. Dr. Maritim, thank you for the excellent presentation and the response to all the questions. We will continue with this at the next. If you have questions that you may want us to consider, please send them in so that we are responding to things that are relevant to you. We will have our next webinar 2 weeks from now. Thank you all. Have a good weekend. Bye.
Bye-bye.
Oh, yeah.
Not yet.